Welcome back. Before we went on the break, we were talking to our distinguished guest today, Professor Tim Eden. He is an oncologist, pediatric oncologist, world-renowned, and presently he has devoted his time and energy and all efforts to the charity called World Cancer Council.
World Child Cancer. World Child Cancer.
World Child Cancer. And we were talking about how he, from one stage to another, moved into child cancer area. And his work has been acclaimed, received critical acclaim. And would you like to say something about that?
Well, modesty means that I must correct slightly. What I think is that I've always worked collaboratively. So we've been very lucky to actually
most researchers do, isn't it?
Yeah, absolutely. We work with a team around us. If anything, I've been quite good as a facilitator, bringing people together and good people and being able to work with them. So the first thing that we really did was to change in a way the way we were treating childhood leukemia. And we worked together to do that as a collaborative group, and I became chairman of the Childhood Leukemia Working Party in the UK, organised by the Medical Research Council. And that was a very privileged time to do, because we did improve the survival each treatment we proceeded. And it was during this time when people abroad noticed, that we were getting better, and we were coming up to being as good as the very best in the world.
They get to know through your published work.
Publications and so on, and also going to meetings and presenting data. And then when we were there, of course, people come from abroad to see what we're doing, and they want to do the same. And then we get into realizing that their results are very poor in developing countries, and the results are very good in Germany, so we all follow a little bit of what the Germans did, and we work together. So it's a worldwide collaboration. One of the problems was that we're now using very intensive treatment to cure the 80% of patients that I talked about. And that is not really possible in low-income countries, one on the basis of being very toxic.
Right.
And it's not what we did at first. We worked gradually up to this. And I think we have to do that. But it's very difficult to tell somebody, there is a treatment that could give you a better cure, but we could probably kill you. And toxic deaths are a worry. So we have to find a way to work together to translate the best. And that's what we've been trying to do. The second thing that we were very interested in was what causes it. And you mentioned that to me when we were talking about things, is what causes it. We don't really know for sure, but we do know that for some, like childhood...
What causes cancer?
Yes, we don't really know for sure in children. We know that the adult type of cancer, smoking and, long life and
just one simple question. I mean, it reveals my ignorance. Is cancer, or is it because the cancer is in bladder is different from cancer in blood, and cancer in the skin and cancer in lungs?
Absolutely. It's different in each of the organs, but what we see in adults mostly are what we call carcinomas. So they have some similarity, but in each tumour there are some different rearrangements of the cells and the genetics within those cells. And I'm not talking about it being genetic in causation, although there is some genetic component to cancer. But it's how the cells are rearranged and what happens. But in childhood, we know that for many of the leukemic patients, childhood leukemia, and probably for some of the brain tumours, and maybe even of some of the kidney tumours, that there are rearrangements of the genes when the baby's being put together that may give you a predisposition to go on to get it. We did a lot of work on that, and we found a lot of negative things, which is quite reassuring.
You were mentioning something like infection, or susceptible to infection.
Well, I think that in childhood leukemia, we know that at birth about 1% of the population will have some gene rearrangements. We've looked at cord blood, from the baby. And we know that about 1% have some gene rearrangements. However, only 1% of that 1% seem to go on to get leukemia, so they have other events. And we've done some work with twins and triplets in my case, where they've had leukemia in more than one of the children, so twins. And we know that they often get the same first event is sitting there, and the second event is very similar, but slightly different. And what we think it is how the body reacts to the exposure to infection causes some break in the genetic material. We're not sure that it's an individual type of infection. We've never found a virus that causes leukemia in children. We know it does in animals, but we've never found the virus. But we think it may be the way the body deals with the damage. And if it doesn't deal with the damage, then you go on to get leukemia. But if it deals effectively with the damage, so it's whether you put the things together again, repair. So repair gene mechanisms. So it's quite complicated to put across, and it's very much easier in adults where, you know, if you're a smoker, you've got a risk of getting lung cancer and so on. But in children, there are not many preventative features. As you get into young adult life, there's a few more prevention things like sun for skin cancer, the hepatitis B virus that can cause you liver cancer, and you can be vaccinated against. The HPV vaccine that can prevent you getting some forms of young adult cancers. But I think generally there's not much scope for prevention. You have to rely on treatment, at the present state of our knowledge anyway.
Why is the treatment so expensive?
Well, it is expensive if you want to cure 100% of cases. If it is not so...
It is a long-drawn treatment anyway.
Treatment can be... Well, it depends on the tumour. Some tumours require quite short treatment. Some tumours can even be cured by a surgical removal, but that's not many in children, or short courses of chemotherapy, but some require... Leukemia requires about 2 years of treatment. We don't know why you need 2 years, but when we've tried to cut it shorter, it isn't, so we don't fully understand it. But the drugs themselves are mostly what we call essential drugs that are right off patent, so there's nobody making a big profit on them, and they're not expensive in high-income countries, but they are in low to middle-income countries, particularly where there's no health service to pick up the cost.
We're very also compared to the income.
Yeah, of course, absolutely. And I think if you're living on, you know, $1 to $2 a day or less, then you can't afford it. And then you require either the country to have a national health insurance scheme, as 1 or 2 countries are now developing, or you have to get somebody else to pay for the drugs.
Some sort of charity.
So drugs and charity is subsidy. That's what we're doing as part of our projects, where we are subsidising, but we're also trying to encourage people in the community to form non-governmental organisations to raise money for that way. In our Ghana project, we've actually been quite successful since we started and made a lot of hue and cry in the media.
You did tell me that you were working in 8 countries?
6 countries where we've now got full projects.
Great.
We've had to close a couple of projects. That is very much related to 2 features which we look for right at the beginning. You must have a local strong leader who asks you for help. If you don't do that, you can't impose on people.
True.
And in one of the projects, we had a young, very enthusiastic doctor who was trying to do a very good job, but she was in a country, and I'll avoid saying where, but it's actually where there was internal strife and problems and dead bodies around, and she just took fright and she left the country, quite rightly. But we couldn't send people as volunteers, because most of our training is from volunteer doctors, nurses, to go out. We couldn't send somebody there if people are shooting people.
You can't cure the dead bodies.
No, exactly. And I think that sort of problem makes us very clear that when we go into a country, we do a very extensive needs assessment visit.
Obviously, a peaceful situation, stability will contribute to a good atmosphere. And medical facilities will be available, people will be free to come to the clinics.
Exactly, and I think stable society means that you can start to spend money not on, you know, military or lots of policing, there's violence, but you can send it on health.
Yes.
And Bangladesh is a very good example of that, where it has had, I know there's ups and downs with riots and things at times, but it has basically been pretty stable. You can have an election and you do elect a new government, and that's crucial. So there has been a lot of money spent to reduce child and maternal mortality.
You went to Bangladesh first time in 2004?
No, before. I've been about 20 years ago. After Professor Manan had came over to our unit back in the 80s, I went there. So quite a long time.
Yes.
But I didn't
how
go for
were you
long.
received? How did they receive your idea?
I mean, very welcoming. It's been very welcome. The problem is that the world has changed, but actually Bangladesh has changed dramatically since our first visit, and you see that it is becoming more able to tackle this problem, particularly as infant mortality has come down with all the efforts to do with diarrhea and pneumonia, vaccination programs and so on. That it's a real paradox, but when you start to stop people dying from infection, then cancer emerges as a problem. It's always been there probably, it may have been missed, but it actually emerges as a challenge to the health services.
So right now you are concentrating, I mean on all your projects are concentrating on children only.
Yes, yes. I mean,
Catching them young.
Yeah, well, the children, that's what we do. We believe that children deserve to have their symptoms relieved. That's very important because very many children come late to diagnosis, and they may not be curable, but no child, we believe, deserves to die in pain. And that's a real challenge to make sure that people are relieved of symptoms. Secondly, we know that many of the children's cancers, as we've shown, can be cured. The question is, can they be cured with affordable therapy? In Bangladesh, at the moment, we are subsidizing therapy for leukemic patients to some degree. We're making some contribution to enable them to complete their therapy. So
under what name, under which hospital are you?
Well, we work, yeah, the project has started in the hospital where there is the most patients coming to it, and that is the, pronounce it correctly, Bangabandhu Sheikh Mujib Medical University Hospital in Dhaka. They see the most patients.
I think that's in Shahbag.
Yes, exactly. And we stay usually at the Dean's Hostel around the corner. Not the Dean's Hostel, the Dhaka Club.
Yeah,
but
it's just
across the
short
road.
walk.
Absolutely. So it's great. We don't have to drive. I won't talk about the driving. But basically,
we'll talk about that in a
yes, exactly. But also there are 8 regional medical colleges, including a couple in Dhaka, that are already linking in with that a little bit, and they come to our workshops, which is really nice. But regionally, we're wanting to gradually link up. So Sylhet and Chittagong are the first 2 that we are actually trying to link into the program.
Tim, it's once again that time that we have to take a break, and then we'll come back. We'll talk about this very interesting topic of this project that you have started in Dhaka, and we'd also like to know how this Bangladeshi diaspora can be of any use to this project.
Absolutely.
Okay, viewers, we'll take a break, we'll come back, and we'll talk about this very interesting topic with our very distinguished guest, Professor Tim Eden.